Probably we'll keep the question at the end. So the next speaker, Dr. Nawaf Almutiari. Dr. Nawaf is known as a gastroenterologist and advanced endoscopist, was working in King Fahd Specialist Hospital in Brida. He did his fellowship program in 2022 at King Fahd Medical City. His talk will be rolling off endoscopy and recurrent pancreatitis.
Bismillahirrahmanirrahim. Good morning, everyone. First of all, I would like to thank the organizing committee for inviting me to speak in this well-known international life conference, and would like to welcome all in this conference as a part of this institute. So my talk is role of the endoscopy and acute recurrent pancreatitis. Very big topic. Try to minimize it as we can. So I hope I will cover the all aspects. Recurrent pancreatitis is a very big topic. Try to minimize it as we can. So I hope I will cover the all aspects. There is no disclosure regarding this talk. So this is my outline. We're going to talk about definition of acute recurrent pancreatitis. What are the diagnostic challenge? Then we're going to talk about EUS and other modality. So what other EUS finding we expected to find in acute recurrent pancreatitis, therapeutic implication, and recent trials and meta-analysis on this topic, and then the limitation of endoscopic intervention in acute recurrent pancreatitis and the conclusion. So first of all, we have to know what's the definition of acute recurrent pancreatitis. We know the definition of pancreatitis, acute pancreatitis is two out of 3 to reach the diagnosis. But the definition of recurrent acute pancreatitis, this patient has to develop 2 episodes of acute pancreatitis with complete resolution. This is Atlanta classification. And AJA also, they defined acute recurrent pancreatitis, evidence of 2 acute pancreatitis without etiology after basic evaluation, including lab workup, CT, and MRI, and they did not include endoscopic ultrasound. So we should know almost 20 to 30% of acute pancreatitis when they admitted to the hospital. Unfortunately, we could not able to identify the reason or etiology. So we know they're going to come maybe within 1 year with another attack. So we have to do an all workup to reach to the diagnosis. What clinical burden, if this happened to the patient, we know they're going to have a high healthcare cost and reduced quality of life. And we should know if patient had 2 attacks of pancreatitis, risk of a chronic pancreatitis, can reach to 30%. So we know the etiology. It's well known for acute recurrent pancreatitis is as usual for pancreatitis. It's a biliary, including microlithiasis, sludge, structure abnormality, usually pancreatic dehiscence structure, metabolic disorder, which is easy to be detected, and genetic causes like SPINK, BRIS, and cystic fibrosis mutation. And we have to know the endoscopic targeting only the biliary and structural disease, which is considered 60 to 80% of the cases. So what are the current diagnostic algorithm in this situation? So if patient admitted with acute pancreatitis, usually initial workup will including labs, transabdominal ultrasound, and CT and MRI. And this is the most of society, they agree about this workup. So if this patient had another attack, you have to go for EUS, which is preferred, or for other intervention. And if patient, you could not reach to diagnosis, you have to go for genetic test, which is very expensive and it's rarely to be done. So what's the pitfall of conventional diagnosis in a CT and MRI? Usually, idiopathic recurrent pancreatitis, it's a well-known etiology, but our problem with the conventional diagnosis, they are missing the diagnosis. They are missing microlithiasis, pancreatic duct anomaly, or any feature of early chronic pancreatitis or neoplasm. As Dr. Balaz, you mentioned, MRCP or MRI, they missed the pancreatic lesion or cyst. So we know the low sensitivity for microlithiasis. So for CT and MRI, so patient had a pancreatitis and you do an MRCP and they mention it's normal. So patient doing fine and to discharge him, we discover few months he readmitted again with the same problem. So most likely this patient had a microlithiasis which has been missed by CT or MRCP. So we know there is intra-observer variability in the pancreatic divisum diagnosis, which is from 10 to 15%. So if three radiologists reading the CT or MRI of the pancreas, 2 may agree and the third one did not agree about pancreatic divisum. Small duct, unfortunately, if it's less than 2 millimeter, that will not be able to be detected by MRCP. And we know that ERCP is a gold standard to diagnose pancreatic divisum if this patient is suspected, but usually this is an invasive procedure. We should not use it as a diagnosis. And we know there is a risk of failure of cannulating of the minor papilla, 10 to 20%. So what we expect if patient had a pancreatitis and we decide to go for EUS. So we expect to find microlithiasis, which usually is not be detected by MRCP, ductal structure or any parenchymal change, which will be in a hyperechoic foci, lobularity, which is early sign of pancreatitis, pancreatic divisum, if you find any dilated duct, non-fusiform dorsal duct, neoplasm, if you find it, it will be easy be detected by US autoimmune pancreatitis, usually diffuse hyperechoic sausage shape. So for pancreatic divisum is usually by US finding. I hope this video is working. So you're going to loss of stack sign, which is parallel of CBD with a pancreatic duct. You will find the pancreatic duct crossing the CBD and duodenal first part. And this one, it's also last week patient with admitted with acute pancreatitis. We did a CT and MRI and turned to be normal. But we did an EUS. We found a small lesion. So unfortunately, it's not working. So it's small lesion. We took a biopsy, turned to be adenocarcinoma. And it has been read by 2 senior subspecialized radiology. So they missed this diagnosis, so the patient was lucky to go for surgery. So let us see the EUS and other modality like an MRCP. If you're going to see the biliary causes as a causing of recurrent pancreatitis, like microlithiasis, the sensitivity of EUS is reaching 95% compared to the MRCP. It's only the 65% to detect microlithiasis. So still, if patient had a pancreatitis, the sensitivity to detect microlithiasis, I'm not talking about CBD stone, which is reaching up to the 65%. So an EUS, if you suspect microlithiasis, patient has to go for that. What about structural anomalies like pancreatic divisum or ductal structure? EUS sensitivity to detect pancreatic divisum is reaching up to 95%, and MRCP is reaching up to the 85%. The reason behind that, because the MRCP cannot detect the duct below 1 or 2 millimeter. So what about secretine MRCP? It's very sensitive, very good modality, but it's rarely to be done in the radiology department. What about the early sign of chronic pancreatitis? US, it's very sensitive, reaching up to the 75% to detect early sign of chronic pancreatitis compared to the MRCP, which is less than 50%. So that's the reason. And US is very important modality in any patient admitted with acute pancreatitis. So this is a key trial and meta-analysis which suggests a role of EUS in acute pancreatitis regarding recurrent or not. So this is a well-known study. They identified the idiopathic acute pancreatitis in 68%. Cosmo trial also, they did a very big trial and they could not find any different except in case of the biliary causes. They found an EUS is high sensitive. There's another meta-analysis which including 1,000 patients, and they found the EUS sensitivity is reaching to the 89% compared to MRCP with a 65% for biliary structural abnormality. And also there is another trials which including 200 patients with suspected early sign of chronic pancreatitis, and they found the sensitivity of EUS is 85% compared to the CT or MRCP, which is 25% and 55%. What is the cost effective? If you say, I will admit every patient with acute pancreatitis, I have to go for an EUS. Yes, because EUS, it can save almost $80,000 per patient for preventing another attack or another admission to the hospital. So what's the expert recommendation? So ACG, unfortunately, they recommend an EUS to be done after a negative transabdominal ultrasound, MRCP, and CT. MRCP secretary is alternative, they mention, but ESG, which is recommending an EUS as a first line for suspected biliary structural abnormality. So in our center, we stopped doing an MRCP. We are doing US for every patient suspected microlithiasis or cholithiasis or any patient admitted with a pancreatitis. Unless the patient is not fit for US, we are sending them for MRCP. So, but we have to know there is a limitation for US. US, it's operator dependence, like transabdominal ultrasound. So they note there is intra-observer variability in chronic pancreatitis with kappa 0.5 to 0.7, which is good. And also depend on operator skill impacting the probe position during the examination. So sometimes we are overdiagnosed the microlithiasis or early sign of chronic pancreatitis. So this is another problem of US. What future it can help? If AI assist image is there, it may help to reduce this limitation. Another limitation of use is availability. It's maybe not available in every center. So that's the problem of US. So endoscopic modality in acute recurrent pancreatitis, you know, that you use for diagnostic, and ERCP for therapeutic, mainly if patient had a pancreatic divism or sphincter of OD manometry going to do it. So let us see the technical success and outcome of ERCP in patient with acute recurrent pancreatitis, and you diagnose this patient had pancreatic divism. We know the pancreatic divism due to dorsal duct obstruction that lead to the pancreatitis. So if you decide to do an ERCP for this kind of patient, we have to know the success of cannulating the pancreatic, minor pancreatic duct is reaching to 89%, and it has to be done in long axis. So, and there is another very good study showing 1,200 patients. They underwent ERCP with minor papillotomy, and they found the reduced of another attack of acute pancreatitis by 85%. Also, there is another well-known study. They mention up to the 70% they reduced acute recurrent pancreatitis post minor sphincterotomy. Ductal stenting also has been noticed if patient had a pancreatic duct structure, which they reduced incidence of recurrent pancreatitis. So take-home message, EUS is first. For any patient presented with acute pancreatitis, you have to go for EUS after doing ultrasound, transabdominal ultrasound, or CT or MRCP. So you should not discharge your patient unless you make sure he doesn't have any microlithiasis or structural abnormality. So EUS is minimal invasive, high-yield tool for diagnosis of acute recurrent pancreatitis. ERCP, it has to be done for patients with pancreatic divism, so to prevent incidence of recurrent pancreatitis. Thank you.